Okay. All right, so here we are to go over our first lab, which is going to be debridement. And I'm going to take my mask off now because these are some extraneous circumstances we have. I would have much rather had all of you present and we could do this together. It's really hard to do a demonstration lab and you can't really demonstrate together. So I'm going to do my best to go over this. Now, you should have already gotten an email from me about a handout that you need to have because you've got a few questions that you need to answer regarding PulseLavage. So if you haven't already gotten that handout, I think it would probably be beneficial to go ahead and get that real quick, and then we'll continue on. So the first part that I'm going to do is let's talk about what's the purpose of PulseLavage. What would we use PulseLavage for, and what is it? Technically, it's a form of non-specific mechanical debridement. So it would be in the same category as whirlpool. And the strength of evidence, if you recall, is a C. And that's not necessarily that it doesn't mean that PulseLavage is not beneficial. It's just that there's not a strong strength of evidence of studies that have been done to support PulseLavage in comparison to other forms of debridement. Now, I can tell you on a personal note that when I graduated, we primarily were whirlpool was our only choice. PulseLavage didn't exist, and I'm kind of dating myself here a little bit. But it wasn't long after I graduated that PulseLavage came into the scene. And I switched over fairly quickly because I'd had a problem with whirlpool for a long time. You know, you're putting a wound in a dependent position into a tank, and you can't really control everything that's mixing in with the water. You couldn't control the force of the jets. And I read a study somewhere where McCullough actually said when he looked at the PSI force of the jets, it was somewhere in the 40s and 50s. And we were always told, you know, get that wound right up close to the jets. You know, little did we know what we were doing. But when PulseLavage came along, I really saw the benefit of several things. Number one, the wound was no longer cohabitating with the rest of the body. You were really doing a specific, more clean method of debriding that wound without exposing it to the rest of the body. You also no longer had the wound in a dependent position, and so many of our wounds are below the knee, and edema is an issue, so we don't want to contribute to that. The other thing about the PulseLavage was you could control where you had the force on the wound. So even though it's, quote, non-specific debridement, I think it is a little bit more specific because you can control how aggressive you want to be in certain aspects of the wound. But again, the strength of evidence doesn't really give us a whole bunch of support for saying, hey, this is a great form of debridement. But I can tell you clinically, when I switched over to PulseLavage, and I had several wounds that had begun with whirlpool and then began to get PulseLavage, it was incredible the speed of healing that I began to see as the dead tissue began to slough off and the wound progressed through the stages of healing at a much more rapid rate. So how does it help? What is it about PulseLavage that brings on that healing? Well, first of all, it's removing the dead tissue in the wound. So it's got that power of debridement, and that's because of the PSI force. And if you recall, when we talk about PSI force, there's a safe range and a non-safe range. So the magic number, think about what that magic number is. And, you know, again, with whirlpool, we were thinking it was in the 40s and 50s, and that was way too much. Your magic number is 15. So with pulsatile irrigation, you should not exceed 15 PSIs, and that's the pounds per square inch, the force of the water hitting the wound. So at 15, it's enough pressure that it begins to lift up debris that's across the surface of the wound without harming the granulation tissue that's present. So that's important to note. That's also important to note when PulseLavage first came along, people were really excited, like me, about we've got to get these units. So people would go to their hospital and say, hey, where are these debriding kits? Unfortunately, a lot of them got some out of surgery. And the PSI force from the surgical kits is much higher because in surgery, the units were used to clean out bone. And the PSI force was often in the hundreds, 200, 300. And being new to the scene, many physical therapists didn't know that there was a difference. Hey, this is a surgical kit and this is one specifically for physical therapy for wound healing. And the wounds, of course, got much worse. And so for a while, people thought, oh, we don't want to do PulseLavage because that PSI force. Well, it was a lesson for everybody. You need to know the product that you're getting, and don't always assume that your hospital put the right kit in the right department. It is perfectly possible that it could be interchanged, and the surgical kits may inadvertently be put in with the physical therapy kits. And it was a hard lesson for a lot of people to learn. So that safe PSI force is 15. The guns that are used in wound management are locked where they can't go beyond 15. This unit that we're going to be using actually peaks out at about 12.8, so we'll say 13. Now there's also a minimal PSI force, and that's where a lot of people, when PulseLavage came out, they thought they were going to save money, and hey, let's just use a bolt syringe. You know, let's just use a spray bottle. Well, there's a minimal PSI force that's also beneficial and not beneficial. And that magic number is really around 4. If you're less than 4 PSIs, you're not really doing anything. You're washing the wound, but you don't have enough force to remove, you know, everything has a molecular weight, and the molecular weight of the bacteria and the debris on the wound, there has to be a force great enough to lift it off. And at less than 4 PSIs, that's not going to happen. Again, in the beginning, physical therapists made a big mistake. They were billing for debridement, and they were using products that did not have an adequate PSI force. And, you know, I say this all the time, but ignorance does not protect you from the law. You need to understand the product that you're using, and does it have a safe range and an applicable range where it's actually doing something. Again, this gun locks out. It doesn't go less than 4, so even at your minimum, you're in that range. So, with that being said, 4 to 15 PSIs is where you want to be. The sweet spot is really from 8 to 15, because when they did a study from 4 to 8, they noticed an increasing improvement in the reduction of bacteria in the wound. And how they did that was they cultured the wound before they did any intervention, and they looked at the percent bacteria in the wound. And then they did an intervention. So they used something at 4 PSIs and then recultured the wound. And then they did use another product at 5 PSIs, at 6 PSIs. And with each increase, the percent bacteria in the wound was reducing. Once they got to about 8, it kind of tapered off. So from 8 to 15, you kind of had a leveling out. So again, you want something about in that range. This gun, when it's fully pulled back, it's going to be in that range at almost 13 PSIs. So the other thing you want to do is make sure you've got suction, and we'll talk about all that setup in just a minute. But let's go back to the types of wounds that are appropriate for PulseLavage. So think about what type of wound would you want to use this technique on. And your first thought is, well, obviously a wound that has necrotic tissue. Yes, PulseLavage is appropriate for any wound that has necrotic tissue. And it would be also any contaminated wound. Maybe this wound has a lot of granulation tissue, but there's contaminated things, such as the patient had a motorcycle accident and he's got gravel and dirt embedded in the wound. And it's a lot of live fleshy tissue, but you've got to get this debris out. PulseLavage would be good to use for that. We also might think of wounds in the perineal area that maybe there's, again, mostly granulating tissue, but then there's a little bit of feces or other unknown debris that could be present in the wound. PulseLavage might be appropriate also for that, to help lift up that debris that's in the wound. And you're doing 3 things. We've talked already about how you're reducing the necrotic tissue. That's the first and primary benefit that PulseLavage does. The second is that it is increasing circulation to the wound. It's that microcirculation. I call it the Hickey effect. And that Hickey effect increases that microcapillary flow. You can easily see when we demonstrate in just a minute, just a few seconds of PulseLavage, and you'll see that erythema response. That, I think, is something that I hadn't thought about when I started using PulseLavage, because many of my wounds were kind of stuck in that inflammatory stage of healing, and then they kind of quit. And that's the thing about a chronic wound. If a patient's had a wound long enough and they have barriers to healing, they've got an imbalance of, you know, too much edema, they've got other metabolic issues going on, that wound has kind of hit that static state. Sometimes it takes something to jumpstart the wound back into that inflammatory stage. And I think sometimes that's what I saw with PulseLavage. it had that erythema effect to the wound, and all of a sudden the wound began to heal again. And again, the third thing that PulseLavage does is it accelerates the healing rate, because when you reduce the bacteria content in the wound can focus more on healing. So it's reducing necrotic tissue, increasing microcirculation, and reduction of the bacteria percent in the wound, so the wound can focus more on healing. What type of wounds would we not want to do PulseLavage on? Because we definitely want to talk about that. So are there any contraindications for PulseLavage? I would say one of the hard contraindications is tolerance. You have a patient who has a very painful wound, and we can think of our burn patients, some of our arterial insufficiency patients. Then we want to think about, if the patient can't tolerate that, then that's certainly not something that we can use. Even if there's great necrotic tissue there, there's so much benefit we could do, if the patient can't tolerate it, it's not going to work. Another one would be uncontrolled bleeding. And you think of your patients who may have a very vascular wound, maybe they have some bleeding issues. Maybe they're, what's the term, your bleeding time is off. And that's something that you'd want to look at if you're about to do debridement. Have they had that done recently so that their clotting time is in a normal range? Because you certainly don't want to cause bleeding and not be able to stop the bleeding. So one of the rules of thumb when you're doing any type of debridement for the first time is you want to have some gauze nearby, so that if they start to bleed, you can apply a little pressure to it, see if it stops, and then continue on. Bleeding does not stop me from doing PulseLavage, but I'm much more cautious as I proceed. And just as a remembrance, if the bleeding doesn't stop after 10 minutes, you need to stop. It's time to move on, because we may need to do some other alternatives. I have had to take patients to the ER before because the bleeding didn't stop after 10 minutes. So again, it's a precaution, but it's not a hard stop contraindication if the bleeding stops after 10 minutes. And the third contraindication really has to do with just demographics. If the wound itself covers more than 25% of the body, you don't want to be doing PulseLavage on that. And the reason is it's going to take you all day. Now that's not to say you can't do PulseLavage on a section of that wound that's covering a massive area. If there's an area you can concentrate on, then you could go ahead and proceed. But if we're talking about a burn or something that's covering such a large area, it's just not feasible to use this technique because of the time element with it. Because you know, PulseLavage is not a time-driven charge. So realistically, you performing this should be a half an hour or less. And certainly some wounds it's going to be more than that, but the charge code is really built in that we're assuming that it's going to take you somewhere around that time. So if you're running into an hour, a little over an hour with this procedure, you may want to think again about maybe PulseLavage is not exactly the most ideal intervention for this type of wound. Okay, so I think I've covered everything that I want to about as far as why we use PulseLavage, what type it is, the types of wounds that are appropriate, the ones you want to be cautious about, and the contraindications. So now let's move into setup, how we're going to set up the PulseLavage, what type of equipment do we need to have on, and what type of equipment do we need to get to bring to the patient care area. Okay, so now let's talk about setup. And before I do that, I want to go back to the precautions and contraindications. There's two other things when I was looking back on my notes that we need to make sure that we're thinking of. One of them is an altered mental status. If you have a patient that's confused, as with any type of physical therapy procedure, you're dealing with water, you're dealing with debridement. You want to make sure that the patient's going to be compliant and can sit there. So that's another precaution and a potential contraindication. And the other one is undetermined foreign material in the wound. And let's talk about that a little bit. I actually had a case at the hospital less than a year ago where we were called to do PulseLavage on an inpatient, and there was exposed mesh from a previous surgical procedure that was in the wound. And so that is also a contraindication. If you have exposed foreign materials such as mesh or tendon, ligament, bone that is viable or is in stages of viability, you really shouldn't be PulseLavaging that, and that's a contraindication. A precaution would be something that's non-viable and there's no hope of recovery of it. That's another story. But you're going to encounter many traumatic wounds where you do have exposed viable structures and you should not be PulseLavaging that. In this case, the physician argued with me and said we needed to proceed, and I actually pulled out the literature and found where it said it is a contraindication to help support, and we were in front of the medical director and the CNO, and it was a big deal. So having your literature and your references in front of you, you definitely want to be able to stand your ground because you know what's right, you know what falls in the scope of your care and what doesn't. And hopefully that'll never fall into your lap, but you want to have that available and know what those are. Okay, so let's proceed with setup. First of all, what do we need to have on to perform this procedure? So at a minimum, we have to have the full gown. That's a requirement. It's an OSHA requirement. We also have to have a mask. It does not have to be an N95 mask, but it does have to be a procedure mask. And we have to have eye covering. Now, as far as eye covering, what if you have glasses? Can you wear the mask and your eyeglasses? Is that adequate? No. You have to have goggles or a splash shield. Now, what I use is a mask that has the splash shield attached. That works easiest for me and it tends not to fog up. So that's my preference. But if you do wear eyeglasses, you may want to put the goggles, I think I've got it, you may want to put the goggles on top, on the outside, and that works too. The distance is a little bit better and you may not fog up when you put your mask on. And then obviously you have to have gloves. Now I'm going to go ahead and put the gloves on because the gloves are going to be important for what we're going to talk about when we talk about getting the suction and everything set up straight. So in the order of putting all that on, if you haven't already covered it, you will be covering it in your acute care. There is an order to put things on so you don't contaminate yourself, especially with removing it, because a lot of times you've got stuff on you and there's definitely a procedure to take all that back off. So let's assume I have on my gown, my mask, and my splash shield. Now I've got my gloves on. The other things that I need, you definitely need some extra towels because there's going to be a little bit of water going around. You may want to use your waterproof or a chuck pad. In the acute care setting, they'll have a lot of those. In the outpatient setting, I usually just use towels. If there's going to be a lot of, if it's a large wound and there's going to be more drainage, I may put a plastic bag underneath the towels to kind of help collect. Then you also have to have a suction origin. I say suction origin because in outpatient, it has to be portable suction. I don't know of any outpatient clinics that have suction on the walls. Maybe there are some, but I'm not aware of that. But in the acute care setting, you will have suction on the wall. And just as a word to help educate you, if you're not familiar with the suction, there's a kit that does have to come from downstairs that goes onto that suction that allows it to become activated. So you can't just go in the room and suction automatically works. There's a kit. Now with what's going on these days and so many respiratory issues, most of the rooms have that kit in the room, but don't assume. Okay, after that, you've got suction. You need a canister, obviously, something to collect the fluid. You need water, saline. And we'll talk about the size of saline bags in just a second. And then you need the gun. And I have one already outside the package here that we'll use. Saline. Let's talk about that. People ask, well, what size saline bag should I use? Well, it depends on the size of the wound. I would suggest in general that you use the 1,000 milliliter. This is 500. This is not really enough for most of the wounds that you're going to encounter. So I would say the 1,000 milliliter bags. Now certainly if you have a really big wound, you may want the 2,000 or 3,000, but you better make sure you get the 2,000 or 3,000 canister. You're going to be in for a surprise about halfway through the treatment. Always keep that in mind. So as far as the saline, one of the things we want to do is, let's think about that wound surface. When we begin the procedure and the saline hits the wound, what about the surface temperature of that wound? Do we want to pay attention to the temperature of the saline on the wound? And that answer would be yes, because think about what the temperature is of this saline right now. And most room temperatures, 70, 72 degrees would be the temperature of this water. Well, think about the temperature of the surface of the wound. It's going to be a few degrees lower than body temperature. So one thing you want to do is heat your saline. I would say in general anywhere from 92 to 96 degrees is going to be adequate. That way you're not really going to be cooling the wound, you're close to the body temperature. And the primary reason for that is think about what's happened vascularly at the wound surface. You don't want to be causing vasoconstriction. You know, here you are trying to increase blood flow to the area, so you need to have the saline at the temperature so it contain and continue to have that vasodilation and that nice erythema response. Okay, so we've heated the saline. How would we do that? Well, if you're in the acute care setting, when you come in the room, turn on the water at the sink and put your saline down in the sink and just turn on the hot water. All the hospitals are required to have a maximum temperature of the heat so that the patients don't get burned. And about 10 minutes running under that saline bag is going to get you up to temperature. It's going to take you about that amount of time to prepare the area, because next what we want to do is put towels around the wound. We want to explain the procedure to the patient. We want to remove the dressings, and we want to have our dressings that we're going to cover the wound with somewhere nearby. And we want to set the kit up. Once we've done all that, we've got our suction ready, that saline is about up to temperature. Okay, so now we've got our gown and our mask and our splash shield on. We've got our saline heated up. Now we're ready to hook up the gun to the suction. So with this particular gun, there is a black pin that's in the gun. Make sure you pull that black pin out. If you forget, you're only going to do it once. I've been downstairs many times and a PT will call me frantically saying that water's leaking everywhere. If you don't pull that pin out, you're not activating the battery, and so as soon as you spike the bag, saline starts pouring through the gun because the battery can't have that stop to it. So pull the battery out. Pull the pin out. What the pin is doing is conserving the battery on the shelf so that as this gun waits for you to use it, the battery is not getting used. Okay, so we've done that. Now we're ready to hook up the two tubes. Just keep in mind right here, one spikes saline and one goes to suction. That looks like a huge needle, so obviously that would be the one to spike the saline. This has blue on it. Think oxygen, think air. This is what goes to the vacuum canister. Okay, so let's do that. We're going to hook it up to the vacuum canister. Don't make this complicated with the canister. All the holes have to be eventually covered up or you're not going to have suction, and it doesn't really matter which one goes where. I am hooking this one to the one that says patient, but you could have hooked it to another one. One has to be obviously hooked to the unit, so this small tubing here is going to the suction unit, and then the other, there's usually always 3 holes, the other hole needs to be closed, okay? Now, to spike the bag, I'm not going to spike this bag because we're conserving things here, but you would spike the bag in the obvious area to spike right here. Now, normally there's a blue covering over this, you just pull that. If you pull that, it's not going to leak. You have to penetrate the membrane in there for it to activate and begin to flow through. Now, do you need to hang the bag? Does it need to be gravity? No, it doesn't. So you could be in a patient's room and lay the bag on the bed next to the patient, and that would be fine because suction is going to pull the saline. So you're fine with that. So for purposes of conserving things, I'm just going to stick this in a water source so that we can perform the procedure. Now, once I turn this on, it's going to get noisy, so I'm going to talk a little bit about procedure, and then once I turn the unit on, I want you to watch my hands. This is where really being able to do this is crucial because PulseLavage, the technique itself, setting things up is relatively easy and simple, but performing it on a patient takes a little bit of practice because it's a two-handed technique. I see everybody the first time they're doing it, they're just holding the gun and going at it. You definitely want to control how much contact that tip makes on the wound because the benefit of the suction and the force of the PSI is enhanced depending on how much contact. It's also more crucial when there is granulation tissue mixed in with necrotic tissue because you don't want to harm that granulation tissue. You want to be aggressive on the necrotic tissue. And let me just tell you, if the wound is primarily necrotic, you have nothing to worry about. Go at it. You're not going to hurt anything, and it's usually not painful. And you can just drag that thing right across the necrotic tissue because you're trying to break it up. The problem is when you have a wound that's mixed. And you want to be aggressive towards the non-viable tissue, but you don't want to start the granulation tissue bleeding. That's why you need 2 hands. One hand holds the splash shield. The other fingers, and I'm hoping I'm staying in your view here, the other fingers brace yourself on the peri-wound area so that you have 2 fingers to hold that tip and control the degree of contact that's on the wound. That's crucial. When you first do this, everybody does it. You lock down and it's too tight and you just can't manage it. What you're trying to do in the presence of having granulation tissue is you're trying to lightly make contact, but not make so much contact that it becomes painful and it locks down on the wound. Now, how you do that? I like to compare it to 2 magnets. If you've ever held 2 magnets and you start bringing them close together, there comes a point where you feel the pull of the 2 magnets, and then it's fun to try to see if you can hold that tension without it locking. Well, that's exactly how this works. You're trying to feel the pull of the suction wanting to lock down on the wound, but you're controlling it with the hand holding the splash shield. And that's why practicing this is crucial, because if you guys ever did the magnet game, I smacked those magnets together more times than not, and it takes some practice to hold that tension and not lock down. So that's the technique that we would have practiced if you had this. And I'm going to tell you that on a plastic bud it doesn't work very well, but in a minute I'll show you on skin how it works better. So once I turn this on, I want you to watch the following things. I'm going to show you the technique of how I lightly make contact. So that's one thing you're going to be looking at. The next thing you're going to see is, what do we do if it locks down? Because it will happen. It's going to lock down and you're going to panic, and the sound, the suction sound starts to increase because suction is increasing, and the patient starts to feel uncomfortable. What you don't want to do is just pull it off, because if you pull it off, you're actually giving a pretty strong pull against that wound. What you want to do is keep your wits about you and break the contact. So if you see what I just did there, and we'll show a close-up in just a minute, but you actually break the seal and then it comes right off. It's one thing to do that when everything's calm, and it's another thing to do it when it's locking down on a wound and the sound is increasing and the patient's getting anxious and you're just wanting it to stop. But you need to keep your wits about you. So that's the second thing you're going to look at. The third thing is the sweeping motion. So the sweeping motion is when we have a larger wound, such as this one here, and the splash shield doesn't cover the entire wound. How do we move around on the wound? And again, that's that magnet tension, how we move it gently. And that's where I'm going to have someone bring their arm in so you can see how it moves better on real skin than it does on plastic, because 2 plastic pieces tend to really collect on each other. Okay, so I'm going to turn the unit on and let's look at those 3 techniques. And hopefully, we had a few technical errors earlier. Hopefully this is going to work. Just thought of one more thing. The suction. So we talked about the PSI force, but what we didn't talk about was the amount of suction. And you guys were looking at your papers going, when's she going to answer that question? Well, here it is. So you want 80 to 120 millimeters of mercury, and that's mmHg. That's the whatever that is afterwards. Millimeters of mercury. And the units that you use, I'm just going to tell you, don't trust what it says. Now you're thinking, but that's a unit. The thing is they don't get calibrated often. I don't know in my 29 years they've ever come down and asked to calibrate the suction unit. They calibrate our dynamometers, but they don't calibrate suction units. It's just not something that they do. So it might say 150, 180, and that probably it's less than. What I will tell you is I've never seen suction be more than what the number shows you. It's usually always less, because stuff starts to collect in the tubing system and its strength of suction is less. So how can you know if it's safe? Because that's really what we're talking about. How do I know I've got adequate suction? That's where the glove comes in. First of all, make sure you have gloves that fit. If they're way too big, it's not going to work. And you shouldn't be using gloves that don't fit you anyway, because you're going to be clumsy. You don't want gloves that are too tight either, because you're going to be uncomfortable. So a glove that fits, what I'm going to do as soon as I turn the suction on is I'm going to check the suction. What you should see is as I make contact with the tip, the first thing I'm looking at is, do I have suction? Because I don't want to start this if suction's not working, because I'm going to have water everywhere. So I'm checking is suction working. If it's not, recheck your connections, because something's probably not sealed. Usually the top to the canister is not snapped down, and that's your problem. If I do have suction, what is adequate? Well, what it should do is, you should see on my glove, is it'll start to pull the glove away from my hand up into the tip, and then it'll let it go. So it'll move it outward just a little bit, like 1/4 of an inch, and then it lets it go. If it pulls the glove all the way up into the tubing, well, that's too much suction. You're going to have a problem. If it doesn't even pull the glove away from my hand, it's not adequate suction. You're probably close to 0. So you're going to need to try to adjust it higher. Okay, so let's see. We're going to look at 4 things now. Suction. We're going to look at my technique as I make contact. We're going to look at how to break contact. And we're going to look at the sweeping procedure, and we'll do that on an arm. Okay, so here we go. So if you guys want to move up close, you don't need to see my face anymore. So that's perfect suction. All right, now, technique. Let's prime the gun. We need to get the water into the tip. So if you notice, the sound changed. You heard it go to a lower tone. Now I know I've got water in the tip. So we're ready to go. I just thought of something else. First of all, don't ever touch your device with your gloves. You're gonna have to change gloves. I didn't talk about the 2 holes here. The 2 holes are also crucial. That helps you maintain control of the amount of suction. And what you're gonna see me do when I make contact is I'm gonna kind of vacillate on those 2 holes, because you'll see the suction kind of pulsate. And what that's doing is it's creating kind of a pulsating, vibrating effect on the necrotic tissue, and it helps lift it up. So again, that's why it's a 2-handed technique, is 1 finger is holding those to kind of control that pulsation. So I'm going to move from here with the pulsation. I'll come over here to this wound, and then we'll bring the arm in. Contact. Break the seal. Okay, let's see the hand here. So to glide, so we can do the gliding technique. If it locks down, that's the lockdown. Break the seal. That's how you can break free. Okay? Practice. Okay, so one thing I wanted to mention from that is you always have suction. I hope you guys heard that. Even when my finger wasn't on the trigger and water wasn't pulsating, you still heard the suction. And that's crucial to know, because you can always gather fluid if it's building up in the wound. Just take your finger off the trigger and continue to put the tip down into the wound, and you'll suck things up. So I'll show you that real quick. But then the other thing I'm going to show you is another tip. Sometimes you may have a wound that has tunneling. I hope you don't ever have a wound that has this much tunneling, but you can't really get the tip down into that tunneled wound. And so there's another tip that they came up with that has a long, thin tip that can go down into a tunnel. Again, precautions, you don't want to go poking things into areas that you can't see or feel, so make sure that it is unimpeded as you penetrate down into the tunnel. If you hit blockage, you don't want to push on that. You want to be real cautious about doing that. So I'm going to show you how to hook up the other tip, and we'll look at how that tip works. It's going to be noisy, so I'm going to describe it to you, but the tip It's right next to me here, but I'll pull it out in a second. But where the water is going to be coming out at the end of the tip and around the sides of it. And that's important because it's sending the force straight ahead as you go into the wound, but also circumferentially along the side. But it's not 360 degrees. So as you put the tip down into the tunnel, you kind of have to spin it. And you'll see me do that as I spin it. And then remember, you always have suction. So you're going to see also that as the water begins to accumulate, if that tip gets down low enough to it, it'll still collect the drainage up. So let's take a look at that real quick. So first, we always have suction. I can retract this shield and still collect drainage because suction is always working, okay? Just make sure you put the tip back. Okay, let's switch tips. So you're in the setting, maybe you have a patient that has different kinds of wounds and tunneling. I'll just remove that tip and then we'll grab the other tip right here. And a few things to note. You know, with so much going on right now with trying to protect ourselves and create barriers and not have aerosolization of structures, one of the things that this company did is they have a protective barrier that I think is worth mentioning, because this kind of eliminates aerosolization if you use this properly. This allows you to put over the wound, and if I put towels around the perimeter, it's basically a sealed area, and then the gun can come through here, and then from underneath, I don't get all caught up in the plastic here, there, from underneath, I can attach the tip and then lay this back down, and now I have a closed structure where there is no aerosolization. So if you are at a place where your infection control is very wary about you using PulseLavage, well, you definitely want to use this. It creates a great barrier to that. I'm not going to use it for right now because it's hard for me to see everything. So let's get this tip out. So this is the long tip for tunneling. It has a protective tubing to protect it in storage. Pull that off. Hook it to your gun. Make sure then that you change your suction, because if you notice, this tip is still hooked up to suction. I've done this before and it was not pretty. Hook it. Switch it. Okay. Alright, so once we have that hooked, now what we're going to do is we should have saline that's going to come through the tip, and I'll demonstrate how it works on here. I'm going to come up real close. See if you can see the water that's going to come through here. So you see coming straight out and on the side. Okay, so now we're going to look at sharp debridement. Now, ideally, I like to do sharp debridement in conjunction with PulseLavage, and I actually would have my debriding kit next to the gun, and sometimes I would set the gun down on the sterile towel and debride a little and go back to the gun. That's a great way to do a really effective form of debridement because the PulseLavage helps lift up the tissue, and then you can use your sharp instruments to cut it away. So let's just do a quick little sharp debridement with this poor little orange here. An orange, if you get the right kind that has the real thick skin, it actually works pretty good for debridement. And it's been a long time since I've used an orange, so we'll all be kind of doing this together. This might be funny. We don't know yet. So let's talk about debridement, some precautions and contraindications. The same as PulseLavage. Again, you want to know about bleeding. You want to make sure that the patient is compliant. You can't put your patient to sleep, and you can't really immobilize them, so they need to be able to be still. And I learned the lesson the hard way and actually cut myself one time when the patient twitched. And it's definitely, you just need to be careful. For that reason, I don't use a scalpel very much because I think you have a lot of iffy things going on with a patient that's awake and a patient that may or may not be able to be still. I'm going to talk about the different tools that we can use in this setting. Primarily what I use are scissors and tweezers, and you can also use a dermal curette. Just see what this is right here. This is a dermal curette, and then also some people really want to use the scalpel. I think the scalpel has its place. If you have a patient that has some thick eschar that needs to be cut away, the scalpel is really great for a technique called scoring, and so we'll demonstrate scoring on this orange. The dermal curette is really great for scraping, particularly if you have, say, a diabetic foot wound. Most of those always have peri-wound callousing, and that wound edge is just very unhealthy. The dermal curette is great for scraping away that calloused edge and getting back down to viable tissue. And then, of course, you've got your scissors and tweezers to grab and lift and do kind of a filleting technique. Let's talk about a few things that I would say you never want to do. One thing you never want to do is have the sharp edge of your instrument perpendicular to the wound. If the patient moves or you stumble or anything, you're going to penetrate the wound. So I have a habit of whatever I'm doing, my sharp instrument is parallel to the surface. My tweezers may be grabbing the wound and lifting, and then I'm trying to stay parallel and not perpendicular. That definitely goes for the scalpel. We do not want to have ever be like this. So when you're cutting, you want to be here. When you start to score the wound, again, you're here, you're not here, okay? So let's talk about the different techniques. Let's start with scoring. Usually it would probably be most commonly with a pressure ulcer, and you've got some, like a thick necrotic eschar flap of tissue that you're really trying to loosen up and work off. I might PulseLavage it first to get it moist and start to soften it up, and then I'm going to create an X on the wound. So I'm going to create kind of a grid, and then I'll form an X. And again, you can see with the scalpel, how deep am I going? Am I cutting into viable tissue? Well, you don't always know. And that's the danger of using a scalpel, is you need to know the thickness of that dead tissue. I like to use the tweezers for that technique because, and I'm going to grab my kit here because I'm used to this scissor and tweezer. And that's one thing that I was talking to someone about earlier. You may not like the kit that you have, but you may not have a choice. So you're going to have to use what your facility offers. So one thing I like to do is find the loose edge of wherever that dead tissue was and start to lift it up with the tweezer. The tweezer is what allows you to investigate how thick is this dead tissue? Where is the live tissue? And I'll find kind of a dog-eared edge of necrotic tissue and start pulling on it with the tweezer. Patient tolerance is another issue. You've got to communicate with your patient. I tell my patients, what's your threshold number? Most of them say, well, after about a 6, I'm not going to be able to handle it. And I said, okay, well, I'm going to go to work. And I'm not looking at you, but if I get close to your 6, you need to start saying 6, and I'll know to back off. So once I have a piece of that necrotic tissue, now I can cut it away. And I've gotten down a little bit lower. And if I find where that scoring was, here is a good scoring. Look how that X is. So this is a perfect score. Look how that necrotic tissue is just lifting up in a square. And I know you're like, oh, that's an orange. The necrotic tissue is very similar to this. If it's ready to be removed by the body, you're going to see that threshold of dead, and then there's the living tissue just underneath. And a lot of times after you've scored it with your tweezer, you can just lift it away. If it's still adhered a little bit, sometimes you'll see strings of tissue, strands that are still holding it. I'll hold it with the tweezer, cut those strands away to free it up, and then lift it up. So we just showed scoring, perfect little X there to help loosen it up. Then we used your tweezers and your scissors to help lift it away. Now let's say, what can the dermal curette do? Well, let's say this is the edge of the wound surface now, and I'm trying to smooth it out. Your dermal curette basically shaves. So it's kind of like, this would be great for when you want, what's that called, orange zest? I'm getting orange zest here now. So this is a great technique to, when you're not really sure, Maybe you're not comfortable using the scalpel because you don't know how deep the necrotic tissue is and you can't get a hold of an edge. That's where the dermal curette is great because it allows you to carefully start removing a little layer at a time. Sometimes you're holding it, it doesn't seem like it's grabbing right. If you flip it around, sometimes it'll get there. See, this side's much better. And now I'm doing the same thing. I'm just not sure where my viable tissue is, so I'm just scraping away to get down to it. The closer I get, I start to see the color change. And then here's where the dermal curette really exceeds. Once we're down to that, I can kind of see some white fascia, but the meaty pulp is right under it. The dermal curette can continue to shave that on down and get right up to the meaty pulp without penetrating. And you see now here, I've got some meaty pulp there now exposed. So again, if you practice your technique, you can get real good at getting down to that meaty pulp. And you know, a lot of times this dead tissue, it doesn't hurt when they're there. It's when you get close to the meaty pulp that you've got to be careful. And then we just scrape away. We can get right down to that meaty pulp carefully. Again, you notice my pinky finger. I'm anchoring myself here. You can't do this and not be anchored. There's no way you're going to control that tension. This contact allows you to control that tension. Okay? So there's all your techniques with doing debridement, and practice with an orange.